So I'd like to invite Professor Richard Lee from Bascom Palmer to talk to us about OCT artifacts and pitfalls. Richard.
Thank you. So no disclosures that are relevant. I wanted to thank everybody for inviting me. And really this work is a summary of the work of the giants sitting here at this podium and many of you in the audience. Really, I'm just privileged to be able to summarize that data for you guys in terms of clinical practice. So let me talk about 3 maxims about imaging. One sees what one looks for. Doug Anderson, the founding member of the glaucoma division at Bascom Palmer, used to go around the world, give his whole talk for 50 minutes to an hour with one slide pulled out of his pocket. It was this slide. It would freak out the AV guy. He had no PowerPoint. He just had this one slide. Well, he had to take out the eyeball to get you that histology slide, and what we'd like to do is do in vivo histology and do that cross-sectional analysis, that en face view of that eye, and get this histology in the live human being so we can follow this person. So the other corollary is one sees what one wants to see. So this here looks like a nice radially symmetric flower in my backyard, but if you do the en face and cross-sectional view, you realize there's a pineapple growing in my backyard. So one has to be very careful in what they see, and not everything that one sees is real. I was taking a trip from Austin down to, from San Antonio to Austin, and saw these beautiful cacti all along the highway, and I just couldn't believe this one mutant, cactus. It was, every one of them was exactly the same. So I pulled over to find out what genus this was, and sure enough, it was actually metal art by this guy. Those are all rivets. And what we really wanted to see was this real cactus at the Tucson Botanical Garden. So with regard to glaucoma, we want to talk about real disease, and that means having structure and function correlation, where a patient with an inferior notch has a superior visual field defect that we can then correlate with OCT to verify that there really is, to the micron level, nerve fiber layer loss. And let's recall, however, that it is not just about structure in terms of following the glaucoma continuum, because one has to look very closely at both the optic nerve head, because the optic nerve head was the first sign for progression in the OAT study in about 60% of the patients. But 1/3 of them, the first trigger for glaucoma development was visual field. Only 7% concurrent visual field and optic nerve head. And the other thing is, OCT doesn't tell you everything. As much as we'd love to think it gives us all the information we need, you can't see optic nerve head hemorrhages, nerve pallor, optic nerve head edema, the peripapillary crescents and the gray crescents and the black crescents in the optic nerve head anatomy. And we'll give examples where there's situations where you can't get any signal at all. So what I'm going to talk about is red disease versus green disease, where red disease is really a false positive. And this came about because many of my patients would come in as a tertiary care referral center saying, my doctor's not treating me. I have this thing, it's all red, and my doctor says, I don't need any treatment. I'm coming to you. Well, they had actually a very good glaucoma specialist who actually understood the OCTs and things that they were presenting for data. So let me give you an example of green disease. So here's a patient. If you look at that OCT, green and green for the right eye and the left eye, green and green, green and green. By then, we switched over to spectral domain, green and green. But if you looked at this over the 5 years, this patient was losing nerve fiber over this entire time because relative to the normative database, they were still normal, but they were losing nerve tissue. It was a taller person getting shorter and shorter and shorter, but still in the regular range. So if you looked at that optic nerve head from the beginning to 5 years later, you can't tell the difference. But OCT, measuring to the micron, gives you that opportunity to see things well ahead. And as I pointed out, you have to look at the visual field. And if you look at this right eye, you can see there's been progression, even though I've been treating this patient aggressively, progression in that nerve fiber layer loss that's associated with visual field loss as that pattern standard deviation is getting worse every year. So this patient could have been seen as being normal, but functionally, they were actually getting much worse. And as Joel pointed out, and Joel did a really great job to tee everything up for me, even though we didn't collaborate on this, the glaucoma progression, I used to do this manually, but now with the Cirrus and other programs, you can actually get that information all at once, and I think it's very important that we do that on a regular basis. So let me give you another example looking at red and green disease together. So here's a patient, could be a lid artifact, could be a superior hemifield loss, looks like it's normal in the left eye, the right eye, But in the left eye, turns out this patient has a hemiretinal vein occlusion. You can see the macular edema, you can see the loss of the nerve here, of the vessels here, the nerve fiber layer here, relatively normal contour. And if you look at the optic nerve head in that left eye, large PVD, sclerotic vessels, dot hemorrhages, that's the inferior hemiretinal vein occlusion, relatively normal looking superior, and maybe a larger cup to disc in the right eye. Well, let's take a look at this again. Actually, I flipped the right eye, left eye. So here, if you look at the right eye, this is the segmentation defect that Joel was talking about earlier. So normal nerve fiber layer. But if you look at the segmental analysis, it looks like they've had a big superior loss. And sure enough, but that's because it's an artifact. You shouldn't see these black spaces, especially if these black spaces are within the scan circle, because that will give you a false number, significantly lower oftentimes, for your nerve fiber layer analysis. The other thing to notice is there's this wing that's missing, and we'll talk about that again in a moment. So rescan the image, and all of a sudden it turns white, well over the normal for the normative database. And actually it looks like it's a relatively normal nerve fiber layer in this right eye, although you can't really tell because there could be swelling of the nerve fiber layer inferiorly from the hemiretinal vein occlusion. So here, much more. Here it's less. It looks normal, but if you look at this nerve fiber layer, I would argue it's not normal. There's an inferior loss. There's this clipped wing, and what I do is what I call butterfly analysis. You should get a nice butterfly wing, you should get a nice butterfly wing, and each butterfly wing should be represented top and bottom. So not symmetric butterfly wings, and inferiorly, it's a clipped wing. That suggests to me that there's glaucoma. Relative to the database, however, if you look, here it's green, here it's all green. Same patient. 2 seconds later, it's yellow over here. 1 micron difference, because that 1 micron determined in the normative database whether you were green or whether you were yellow. So you really have to pay attention to these values relative to the normative database, because this patient was actually above normal and getting worse. So the normative database is important to understand. It's very different for each of the different platforms. And with regard to the eye, there are going to be those situations like this, where this is a patient with high myopia. You can't even tell where the disc border is. There's a ring here, there's another ring here, it's all tilted, and there's all this loss of nerve tissue. Same thing here. This is what we dreamed OCT would tell us, right? You know, you can't figure out what's going on with this nerve and if it's getting any worse, but here's the problem. Bad visual field taker, high myope, bad visual fields. You get a macular OCT barely, and you can't even get an optic nerve head OCT because the axial length is so long, there is no signal. Worst case, no disease. So this patient, we were not able to get a nerve fiber layer. This actually was just a few weeks ago, so I threw this one as a cutesy. No nerve fiber layer, and the anterior segment, sometimes when you see this GCC pattern, can suggest retinal edema, macular degeneration, or whatnot, had a normal GCC. That's a prosthesis that was imaged by accident. So you can have an eye and get no signal. You can have no eye and get a normal signal. So I just wanted to highlight the fact that you really need to look at your scans, because the fact that there was no cross-sectional OCT tells you there was something wrong there. So the variables that affect OCT results, machine-dependent, operator-dependent, patient-dependent. Joel did a fantastic job of going over this: calibration, segmentation issues, motion artifacts, blink artifacts. Variability in your technicians. On the 4th floor in the glaucoma service, great optic nerve head OCTs. 1st floor retina service, I don't think they can find the optic nerve sometimes to get an OCT, and we don't get great signal strengths. Media opacities, length of the eye, optic nerve head anatomy can affect it. So in summary, in reviewing and going over a glaucoma OCT, we always get at least 2 to 3, and I usually get at least 3, if not 4 OCTs at the same setting, so I can have that comparison, see those small differences between each OCT scan, check the signal strength, like Joel said. It's important to have a signal strength of integrity, or else you're going to be underestimating your values. Check the segmentation, review that butterfly pattern, follow the average nerve fiber layer thickness with that progression analysis, look for symmetry, and lastly, look at the visual field and look actually at the optic nerve head, not just the scan. Thank you.